Okay, I should be recording. Okay, so if we look at this slide, and sedation. Oh gosh, my last lecture, I completely lost my mouse and couldn't do anything. So bear with my computer. I had to reboot, and it's being stupid this morning. Um, the CNS depression is obviously they're a little bit more dull, drowsy. It can, and sedation can vary from light to deep because we can give a lower dose and just kind of take the edge off, or we can give them a deeper dose and make them much more unaware. They're never fully asleep when we do either of these. If we go under tranquilization, drug-induced state of calm, which is a CNS depression, the patient is reluctant to move, is aware but unconcerned. So the difference here is sedation. The patient can be aroused by a noxious stimulus. It says it in the notes page. And a noxious stimulus is something like of an annoyance, or it can cause, and this is when I was explaining yesterday, and like I said, I've seen this happen with animals that are laying there. They lull you into a false sense of security because they are laying there asleep. But someone could slam a door or walk in the room and go, "Hey, Riley, I had a question." And then your dog goes, "Whoa." And then you're like, "Where did you come from?" With tranquilization, someone could come in the room and say your name, and they might kind of look, they might give you a look, but they're not necessarily going to do much about it. Now, but again, sedation, like when I was talking about like a nail trim, or we just got to draw blood on a cat and she's not very friendly. We tranquilize something, that's something we want to immobilize at a deeper level. So, but the key thing is in both of these, the patient is somewhat aware. Tranquilization, you're going to get more immobilization. Does that make more sense to you, Riley, and to you, Michaela? And I realize a lot of times people will use these words interchangeably, but that's probably the primary difference, is that sedation, they could react a little more than they would with tranquilization. But think about, like I said, tranquilizing an elephant, tranquilizing a tiger. We use that term in zoo animals, which you obviously need more immobilization. And I don't want to layer another area of confusion, but when I get into drugs, acepromazine is a drug a lot of clinics use, pills, injectable, and it is technically called a tranquilizer. If you give it in a low dose, it just takes the edge off. So some drugs are called tranquilizers, and that they give us sedation. So that's the primary difference that I want everyone to realize, though. Sedation, more awareness, can be, aroused. And a noxious stimulus is something annoying, but it could be pulling on their leg, them hearing a loud sound, and that's why I'm really quiet around sedated dogs. And sometimes, and I hate when people walk in the room, like if someone came to talk to you, Riley, and you're like, you could walk in the room and go, "Riley, I have a question." You have a sedated dog. Sometimes people even put, we've done this before. There's some drugs that really sound sensitive when they get hydromorphone, oxymorphone. They're very sound sensitive. We'll put cotton balls in their ear. And this sounds weird. I usually put a piece of tape on the top of their head, cotton in ears, so I don't forget to take it out. You don't forget to take it out. But if we're going to do a procedure, that's something we could do potentially to help, is just kind of shove some cotton in their ears, and maybe it'll muffle any sounds, because they can get really like jerky every time someone gets a little loud. So always try to be quiet and calm around them, not abrupt, not loud. I've even sometimes, when we've had animals in x-ray, we've had put a sign on the door, "Sedated animal." Hopefully someone sees it when they walk in and they don't start talking. Sorry, let me go back just a minute. So again, it's drug-induced drowsiness, various levels. Again, if you go back here, anytime you give a dog a drug, any kind of a sedative, any kind of a tranquilizer, depending on the dose, you're going to get somewhere in this sedative category, but they are still conscious. They're just dulled. And then we're going to get into drugs that put them into hypnosis or narcosis. Now we're traveling closer to unconsciousness when you get into the hypnotics and the narcotic or the narcosis. So if I get to that slide, a hypnosis is a drug-induced sleep-like state. Well, think about if you were hypnotized. You know, you're kind of like, you're in a sleep. We're really preventing them from being able to respond to a stimulus. Now, sometimes you can shake the patient, move them, you know, sometimes you can get them aroused or awoken if you give enough stimulation. But I will give you an example. Propofol, which I will talk about a lot because we use it at school and a lot of practices use it, is called a hypnotic. It's a hypnotic agent. So when you give it, propofol puts them in a drug-induced hypnosis. They are asleep. Now, when you fully give propofol, you can shake that dog all you want. They're not going to wake up until it starts to wear off. But if you give it lightly, again, that's a drug that we can give in varying levels. But a hypnosis or a hypnotic agent is going to put them more in a sleep-like state. So that is deeper than your sedation and tranquilization. And then if you use narcotic agents like the morphine type drugs, then you're going to get the similar situation like a hypnotic, but you've just used narcotic agents. So narcosis and hypnosis are a very similar state of consciousness, just one was done with drugs that are narcotics. When I get into the agents, when I get into the anesthetic agents, you will get, you know, we'll talk about like morphine, fentanyl, the drugs that do, but anytime you hear narcosis, narcotic, these are the opioid drugs, morphine, fentanyl, butorphanol. There's a family of drugs that will do this. So hypnosis, narcosis, the only difference is the agent. Similar state of consciousness, different agent. So does anybody, if you have questions about that, just go ahead and throw it out there. I talked about this area as anytime we talk about local anesthetics, this is when we're giving it to a specific area of the body. So when you use a local, like when you go to the dentist and you have a tooth pulled, you're going to get a local anesthetic. You are awake. The area that is being worked on is numb or the nerves are asleep. So this is what we'll put an infiltrate, is when you put a drug in an area, typically around a nerve root, okay? Now, the different ways that we give local anesthesia, if you give it topically, you're gonna put it on top of a wound. I don't know if anybody's ever had to have like lidocaine gel. Sometimes you have a wound, you put this gel and it's lidocaine. It's numbing the surface nerves. You know, this would be potentially, you can squirt it. You can draw up, when you guys get in the clinic, there's a bottle of lidocaine. Well, first of all, it's an emergency drug. And then second is we use it for numbing for procedures. There's a various ways, but if you just pull it up in a syringe and squirt it on a wound, it will numb the surface of the wound. You don't always have to inject it under the tissue. Like when we intubate cats, we squirt a little bit on the back of their vocal cords so that, because cats like to spasm. When you try to intubate, they like to close their laryngeal folds. If we put a little numbing agent, hopefully they won't close them while we're trying to put the tube in. So we'll talk about that when we get into intubation down the road. Regional, this is when you're blocking like a nerve root. Or a nerve block. So like I said, when I had to have a root canal and I had to have work done on a tooth, they put an infiltrate here, but it blocked the root of a nerve, so it blocked all the nerve endings going back. So if they deposit a large amount of numbing agent at the region of a nerve root, it's going to, you know, numb a bigger region. So regional anesthesia is just blocking nerves in a region, the flank of a cow, the roots of the dental arcade, putting it in when we do an amputation. If you guys remember from anatomy dissection, in the armpit area, this is called the brachial plexus. There was a bunch of nerves that fed the forelimb. The doctor will block the branch of the brachial plexus. The whole nerve, the whole foreleg will go numb. Okay, so that's like a region. You're blocking like a so Haley said like a declaw. So if you do a declaw, you do something called a ring block. Well, look at my hair tie. If you put local anesthesia right where my hair tie is, it's going to block all the nerves to the paw. That's a regional block. And then Ashlyn, yeah, you're putting it around a nerve root. So, well, local anesthesia is you're numbing an area. Regional anesthesia would be like you're blocking a nerve root. So local anesthesia is anytime you use numbing agents at all. And then we have topical, regional. Does that make sense? And then an epidural is you're blocking, you know, the pelvis of the, you know, so you're blocking the nerves that control the pelvis. Amputation, stifle surgery. Yeah, so regional is a type of local. Yes. So Ashlyn, hopefully that makes sense. Correctly, regional and topical are types of locals. Yes. And again, we will use these nerve blocks in addition to anesthesia. Like when you do a declaw, you have to have the cat anesthetized. And added analgesia, that cat is going to need less anesthetic if you block the nerves. You don't have to do a ring block for a declaw. You can just anesthetize them and do a declaw. But if you think about it, if you numb and they don't feel this, do they need as much anesthetic? Right. I'm going to talk about another preaching moment is something called anesthetic sparing. Let me go ahead and type it in. I was supposed to. So local anesthesia, think of it this way. I can either just I can take a cat and mask it down with just isoflurane, and we could declaw that cat. Well, the doctor could. I am probably going to use a lot of gas anesthesia if that's the only thing the cat is getting. But if I give it a pre-med, and if I give it an induction agent, and I give it a local block, I'm probably going to use less of my gas. Gas anesthesia has a lot of side effects. There's a lot of side effects to inhalants. So the goal is to run as low of an inhalant as possible. It's going to have less side effects on my patient, and my patient is going to do better. That is the whole gist of this balanced anesthesia. This was the soup analogy yesterday. I talked about making soup. And if you only use salt, you are going to use a lot of salt. A lot. But if I throw in herbs and chicken broth and onions and, you know, I'm adding other things, so then I can probably decrease my salt. Salt is my offensive ingredient. And I want to bring down the level of salt. Think about you're making this for your grandma that has heart disease. She can't have salt, or she can't have a lot of it. So let's make it flavorful. Balanced anesthesia is using multiple drugs, and you need to know the definition of this, because this is the whole theory of how we do anesthesia. Multiple drugs in smaller quantities, and it maximizes the benefits of each drug. And it minimizes the adverse effects. And I know So, you have a lot of different veterinarians out there that feel different way. You have old timers. Some of you maybe have worked for a guy like, he's been practicing forever. You've got these younger vets come out. They're used to the newer drug protocols. And so obviously it's the veterinarian's choice. But I've heard of doctors that are like, it's just safer, let's mask them down. And that's probably the worst thing you can do for a patient because it causes stress. And there is, in that article I sent you guys yesterday, which we haven't gotten into a lot of topics that will help you understand that article, but it talks about how detrimental it can be to mask a patient that's completely awake. That's a lot of stress. You're forcing a mask. They have catecholamine release, arrhythmias. If I can calm that patient down by giving it a sedative, put it in a cage, I get my stuff set up. When I bring the pet out, they're kind of already asleep. And then I place their catheter, and then I give them an induction agent, and then I can run less inhalant. And that gives me lower side effects of each agent. I will tell you, isoflurane and sevoflurane, which are two anesthetic gases, at higher levels have some not great side effects. So my goal is always to run as little as possible of those agents. So that's just, that's out there. Some people think that it's safer to not give all these drugs, but like I said, we're not giving a lot of these drugs. We're trying to give them in lower doses and they work together. ACE and butorphanol or ACE and morphine are beautiful together. They enhance each other. Kind of like how, spices work together. Onion and garlic together versus just using straight onion. They kind of enhance each other, make a better flavor. So hopefully this is making sense. Balanced anesthesia is a big thing. Now, I'm going to keep coming back to these concepts, but like, what do you do as the veterinary technician anesthetist? And basically, we set up the machine, we operate the machine, we make sure we have oxygen. So, I want you to be able to tell me what are some roles that you would have in this anesthetic sparing? Yes. Ashlyn asked a question and said, is anesthetic sparing and balanced anesthesia the same thing? Yes. So the goal is, by doing balanced anesthesia, you can hopefully spare doses and come over with this lower doses overall. So normally what I do, and at the very end of anesthesia 2, so you have anesthesia 1, anesthesia 2, and then you go to surgery rotation, I kind of give you a whole step-by-step. What is your role? What are some things before you go into surgery? It's kind of like a checklist. And it's like, are you prepared to do all of this? I give you a whole little thing. But what I normally do is we've done the physical on our patient. I give them their little sedative and I put them in a cage, and then I go set up my anesthesia machine. Because while the patient's cooking, and that's what I call it, like I stick them in a cage, I'm like, go cook. I can set up my fluids, I set up my anesthesia machine, I check my oxygen, I check my inhalant. When my patient is asleep enough, 15, 30 minutes, I pull them out and then I place the IV catheter. And then usually the technician administers the anesthetic or the induction agent, which takes them from semi-conscious to unconscious. You have to place the endotracheal tube, secure that, and then once you hook them to the inhalant, now the technician begins to do the monitoring. So, normally the technician, and also in a practice, a lot of times the technician is doing the dental and monitoring. You're doing both. So, you're watching the patient. It's nice in a practice if you can have one person doing anesthesia and the other person doing the dental, but that doesn't always happen. And what we will do is that we are going to build to this. We're going to go over anesthetic machines. We're going to go over anesthetic agents. How do you intubate? How do we troubleshoot intubation? And how do we monitor? what are we looking for when the patient's asleep? What are our, signals, so to speak? Now, part of being a good anesthetist, again, is understanding the risks, understanding what happens. So first of all, we usually calculate the drugs, but I always have somebody check my math. You guys will calculate, Dr. Ritz checks it, or Mrs. McClure will check it, both of them. And then when you go to draw it up, they will check your syringes before you give it. So there's like a double check there. It's like, well, sure, you can do the math, but can you draw up the right amount in the syringe? And so you have to make sure you're staying with your calculations. We will practice calculations on tests. So we're going to do some calculations this term, just basic anesthetic calculations. And then obviously being able to interpret vital signs and depth. One thing, yes, so Haley, when we do this, you sedate the animal, you anesthetize the animal. Now your veterinarian is either in the room, they could be, like sometimes my boss has said, go knock down the spay. I grab an assistant and I knock the spay down, and they're maybe with an appointment or they're in their office. So they're not always there right with me, but it depends on your comfort level. As they get comfortable with you, as you get comfortable with anesthesia, my boss would just be like, call me when you're ready. I'd have the patient anesthetized, down, clipped, prepped, and I'm like, we're ready to go. So yeah, when giving the meds, do we give the minimum dose in case? Yes. So Caitlin asked a good question, and I will come to this when we talk about drugs. This is actually perfect for my soup analogy. It says, do you give them the minimum? And she said, sometimes at work they give extra. Normally you calculate, somewhere in a range, or like when I calculate propofol, I might calculate 6 mg per kg, but I give it slowly to effect. If I give acepromazine, it's always better to give the dog the lower amount because you can always add more. Think of it like if you're making soup. If it calls for like 4 tablespoons of soup and then you put it in and you're like, damn, that's salty. Can I take that salt out? I already put it in the soup. I probably could have added 2 tablespoons of soup, tasted it, and went, it needs more. I'll put in another, taste it. Okay, I'm good with 3. You can always give more. You cannot always take it away. So remember that with anesthesia. If you're ever unsure, like if a dog is going to need that much, you can always give them more. If they're not asleep enough, you can look at them and go, because I've sometimes given pre-meds and I have a dog that's like a pogo stick. And he's bouncing off the walls. And I'm like, I don't want to wrestle that dog for a catheter. And sometimes we give a dose and then he's still looking at me like, and I'm like, I'm going to give you some more. But if I slug him right off the bat with a super high dose and then he's bottomed out, you can't always take it away. There are some anesthetics that are reversible. We'll go over anesthetics that are reversible and non-reversible. Like acepromazine, you cannot reverse it. Once you give it, you're stuck with the effects. So if you give an overdose of an anesthetic, you have to treat the symptoms. You're stuck with the effects. It would have been better to back off. So Caitlin, that's kind of a difficult question, but it brings up a point that I'm glad you brought it up, because it's like, you can always give more, but you can't always take it away. That's a kind of burn in your head statement. So when I told you guys yesterday that my boss had given me autonomy because I knew his dosages, so sometimes I'd bring the patient back and I would pick the dose and I would give it. But I would look at the patient and I'm like, I'm going to go lower. But I knew it's safer to give more than go too high, and then I have to, I can't take it away. So hopefully, does that make sense, Caitlin? One thing also, the challenges in the wrist anesthesia obviously, I'm going to have you guys, one of the things that you guys will need to do for me this term is you're going to make a cheat sheet. You are going to make kind of like a crib sheet. You are going to have some information about vital signs, and you're going to have some information about interpreting anesthetic depth. I'll have to find a picture. I have a student, it was Kim McClintock, and she made this beautiful clipboard. She was going to have a clipboard for surgery rotation, and on the front and back of her clipboard, she made this cheat sheet, and then she like duct taped it and laminated it to her clipboard. So if she was in surgery and she wanted to check the heart rate or the blood pressure, the pulse ox, she could look at her cheat sheet and go, okay, and we don't mind. You're not going to memorize all of this before you go into surgery. You can have a like a cheat sheet or something with you. I don't like people to write paragraphs in novels, because if you're concerned about the heart rate and you're flipping through a little notebook, you need something quick where you can go heart rate, blood pressure, pulse oximeter. So I will show you examples when we get to monitoring so that you have some kind of a reference when you're in surgery. And so, you know, you will be asked during rotation certain questions, but I don't always expect, I mean, it's not by me, I'm not in there, but I wouldn't expect someone to remember it right off the top of their head. But if you had a little sheet with you that could help you, then you would be prepared to troubleshoot. So how do you interpret depth? How do you do this? And you have to do this and get multiple pieces of information. The ultimate thing that we're trying to prevent is the anesthetic accidents. And that's when I said I will teach you how to do this safely, because you have to balance that. But that's the whole knowing your patient, know your drugs. If I understand any risks my patient has, if I understand the side effects of the drugs I'm using, then the pay attention part is my patient responding appropriately? Is their consciousness level appropriate? Heart rate appropriate? Okay, so you have to balance all of this information. And the biggest thing I can say about an anesthetist is they're paying attention to detail. They are checking, you know, I don't know if you've ever watched when they do surgery there, a lot of you guys are at the window and, you know, they're moving the jaw up and down. When a dog is awake, they have jaw tone. When a dog is dead, they have no jaw tone. And then there's dogs that are in between. So I am constantly, when I do anesthesia, I'm constantly fiddling with their jaw. I'm constantly, because as my patient is deeper, their jaw gets really loose. When my patient starts waking up, their jaw gets really tight. Jaw tone tells me a lot. Eye position tells me a lot. We will build this into monitoring. When a patient is awake, they're looking at you. When they're dead, they're looking at you. So when I have an animal under anesthesia and I see that the eyes are pointing straight ahead, am I getting ready to wake up, or am I getting ready to be too deep and close to death? When an animal goes to sleep, their eyes roll down and they roll in. When they start to get too deep near death, they roll back up again. So eye position is huge for me. Eye position tells me I'm always checking their eyes. I'm always checking their jaw. Obviously heart rate and vitals, but those other two parameters give me a really good feeling for where my patient is. And then I have to move accordingly. So I'm constantly interpreting eye position, jaw tone, heart rate, blood pressure, mucous membrane color, body temp, and I'm trying to make an assessment. So, and again, this will get easier with each case you do. So it's just you being prepared when you go in there. And obviously the calculations are huge. So I don't know if you remember from pharmacology that some drugs have a narrow therapeutic index. So their dose, is very narrow. I'm gonna give you like propofol. Propofol dose is 4 to 8 mg per kg. That's the range that we give it. 4 is for the dog that's pretty sedated or kind of out of it. 8 mg per kg is the dog is like insane, bouncing off the walls, didn't pre-med well. Okay, so there is a window there in my dose, but some drugs will have a very narrow window. 4 to 8 is not bad. Rami, the dose, like propofol, is 4 to 8 milligrams per kilogram. And I know you learned in well, I just did pharmacology. So I just taught pharmacology 1. And I know when you're given a range, they say calculate the low end and the high end. And if you're anywhere in between that dose, you're in that dog's therapeutic range. Now, I will usually pick one of those doses and then calculate, like I said, if it's 4 mg per kg, the dog's like a bump on a log. 8 mg per kg is for the dog that's bouncing off the wall. So that's my, but there's drugs. This is something else you will get good at, okay? I have a baking analogy. I was making banana bread the other day, and I went to do the recipe, and it said like 4 cups of butter or something. And I was getting ready to put the butter in, and I went, I've never used 4 cups of butter for any recipe. And then I turned around and I had mixed up 2 of the ingredients, and I read butter wrong from like the buttermilk or something or flour. And I almost made the recipe. And I would have totally messed it up because I would have used like 2.5 sticks of butter. And I was like, I don't ever use that much butter. I have sometimes gone to draw up drugs, and I calculated it, and I go to draw it up and I go, oh my God, that's a lot of drug. Hang on, I'm getting a little, okay. I probably froze. I've gone to sometimes draw up a drug and I go, that's a lot. And then I go back and I do my math and I miscalculated. The feeling I got of when I drew up the drug, because I was used to drawing up that drug multiple times, and that was different. So there's sometimes a gut feeling that I was like, that's a lot or that's not enough. And again, that's something that will build with you guys. The more you do anesthesia, as you realize, how much of a drug you usually use for a size of patient, and then you could catch yourself. But what I always say when you guys are starting out, and probably wherever you do your externship or wherever, they're going to check you for a while. They should. Nobody should feel offended that somebody wants to check their math. Whenever I calculate insulin, and I've been doing this a really long time, I'm like, somebody check me. Because if I'm having a brain fart day or an old lady day or whatever, I'm like, somebody make sure I know what I'm doing. So when you're starting out, you got to make sure a decimal point can mean a big difference when we're talking about anesthetic agents. So you got to be very close when you're looking at this. And then again, checking any changes in cardiovascular. Anesthetic agents, first off, affect the central nervous system. They depress the CNS. So we're like taking away their level of consciousness. But most of the drugs alter their cardiovascular and respiratory function. So that's why we monitor heart rate, blood pressure, gum color, your mucous membrane color. And you have to realize which changes are moving in a danger zone. And that's why we give you minimums and maximums. And I will tell you, if you see this number, you are concerned. If you have a pulse oximeter reading and it's 90 or below, you have a problem. It needs to be fixed. And I talk about troubleshooting that. What does it mean? How do we fix it? So that's what we're talking about, is because these drugs will alter that. So we'll get into how do we monitor for those situations. And unfortunately, when you're first starting off, you're trying to develop that pattern. Like I have a pattern when I do anesthesia, and it's second nature. every time you do anesthesia, you're going to come up with a pattern of what you do things. But you have to look at the animal visually, touch, tactile. Like I tell you, I'm going to tell you something real quick. I was I was at Purdue, and these were veterinary students. They were junior veterinary students. It was a surgery lab. They were learning how to do anesthesia. I had a group of 3 guys. We had a hound dog. All they had to do was anesthetize the dog, keep it asleep for half an hour, and wake it up. In 2 weeks, they were going to be doing surgery, so they wanted to make sure they knew how to do anesthesia. I'm with the guys. They anesthetized this dog, and I'm talking to all 3 of them, and they're doing fluids and the monitor. And I reach over. I'm not even looking at the dog. I just reach over and feel the dog's jaw tone. They just anesthetized the dog, and they just intubated him. And when I went to open his jaw, it was extremely loose, and it hit me in my gut. And then I turned and looked at the dog, and I said, "Get a pulse." And I opened his mouth, and it was super wide, and he was extremely pale. And I turned the dog off. I said, "Turn off the dog, get me the anesthesiologist." And I said, "Go get me atropine. Push fluids right now." The dog was probably about 5-10 minutes away from death. And when we woke him up, he blew out this awful diarrhea. I mean, god awful. And the student told me, they said, "Yeah, well, he's been having vomiting and diarrhea for a couple days." And I was like, "Did you let anybody know that this dog had not been feeling good?" But I think when he was anesthetized, the dog was not in a very healthy state. And I think the anesthesia bottomed him out. How did I find that problem so quickly? I touched the dog, and he felt looser than normal for a dog that just went under anesthesia. That jaw tone should not have been that loose right off the bat. And then I listened, auditory, and his heart was really slow, and he was very pale. Now, when you have a dog that just first goes under anesthesia, they should still be fairly pink, the heart's beating, they should still have some jaw tone. So you see, I picked it up by touching the patient. Yes, so Ashlyn said, cannot reverse anesthetic effects. The reason we gave that dog atropine is a drug, it's an anticholinergic, and it raises heart rate. So because the dog was so bradycardic, the heart rate, I want to say it was like 30 or 40, and none of the drugs we gave that dog should have made the heart rate that low. So that's why, and as soon as I called my anesthesiologist, I didn't give the atropine, I called for him, but I already said, "Get me the atropine," because I knew, I'm like, we need to give this dog atropine. And I turned off the gas because I'm like, we got to wake this dog up because this dog is way too deep right now than he should be. And then he gave the atropine, the heart rate came up. We pushed the dog some fluids because we couldn't feel a great pulse. So we gave him a fluid bolus. And it's a good thing we did because the dog, we think, was dehydrated from having a couple days of vomiting and diarrhea. And I think that's why he had such a profound effect to anesthesia, was he was just probably dehydrated, probably not very healthy. We gave him normal doses, but we did not know that the dog, like I said, this was a unique situation because it was a lab dog that was an in-house lab dog, that didn't get communicated. Does that make sense? So you have to be touching your patient all the time. It's just something I do, and I cannot, tactile is touch. So I sometimes just the feel of a dog under anesthesia, I can feel when they're too deep and I can feel when they're too light. And that's always touching. And then using the monitors. One thing I will tell you guys, and I last term or the term before, I had to help a day in surgery, help the anesthetist. And she was trying to get a heart rate, and we had hooked up the EKG, and the EKG or the monitor gives you a heart rate. It went to 60, 250, 140, 80, and she was like, "Miss Landeros, what am I, it's like all over the place." And she's trying to look at the EKG. I said, "Put in the stethoscope and listen to the heart." And the heart was going boom, 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 boom. But what they were doing to the animal, they were scrubbing it for surgery. They kept bumping the legs. They'd hit the wires. And so the ECG was doing all this stuff. I said, don't look at it. Don't even look at it right now. I said, just listen and tell me what the heart rate is. And once she heard that, she was like, oh, I said, use that for your heart rate. Because if you look at that number, sometimes Dr. Ritz, like they'll bump the cords when they're doing surgery or somebody is scrubbing. And so you have to learn to use the monitor for what it is, use your stethoscope for what it is, feel for what it is, and you have to interpret all that data. But what I've told you before, and I hope you take this to heart, is I just had this lecture in anatomy and I was talking about the electrical activity of the heart. Remember, the EKG is measuring the electrical function of the heart. You listening to the heartbeat is the heart pumping. That's the most important piece. And remember, they are supposed to go together. But whenever my ECG, whenever I don't like my number or I don't like the rhythm, the first thing I do is I put my stethoscope in or I reach under the drape and put your hand on their heart. As long as you don't touch the top of the drape and mess up sterility, you can put your hand underneath and literally touch the dog. I think some of you were working on there was a case in radiology, I can't remember what class it was with, and they were looking at the dog and they were like concerned about something on the pulse oximeter, and everybody was kind of like, I don't know, what do we do? And I was like, somebody get a stethoscope or put your hand on this dog's chest. How are you going to, we got to make a decision. And you can't stand there paralyzed. I'm like, if you cannot hear the heart, you can feel it, you can feel a pulse. That's going to be the easiest way to confirm, do you like what the ECG is telling you? If you don't, listen to it or feel a pulse. That'll give you your answer. And as soon as she did that, as soon as she listened, she realized what the ECG was telling her was not accurate. And that's the fastest way to figure out if your ECG is something that we need to, if the heart you listen to matches what you see on an ECG, then we got to do something about it. Does that make sense? And we're going to build all this. I'm just kind of giving you guys, how do you take all this information and put it together? You always err on the side of caution. Like the dog I just told you about with those students. My immediate reaction was, I don't like what this dog is doing. I turned off the anesthesia. If the dog wakes up and it's normal, I can always turn the anesthesia back on. And they could be like, wow, Christine, you were off. And I'm like, my bad. But it's always better to err, like I said, better light than dead. It's going to be better for me to turn off the dog and verify the situation and then turn them back up. In my scenario, I was right. And it was better that I turned the dog off because the dog was not okay. Does that make sense? Hopefully it makes sense. The rapid decisions will come with experience. That's why you have the cheat sheet. That's why we give you those tools so you can learn to interpret data. Now, physical parameters we will go over, okay? What is heart rate supposed to be? What is blood pressure supposed to be? What is SpO2 supposed to be? We will go over the equipment you're using, the monitors, the anesthesia machines, the oxygen. How do you troubleshoot a machine? How do you understand the values your patient's giving you? And then understanding, when you understand our monitoring devices, everybody thinks I hate ECGs. I've had multiple classes go, it sounds like you hate an EKG. I don't, as long as it's used properly. I've just seen and I've worked with students a long time. Purdue, here, I was at Harrison a little bit. I mean, I've had students stare at a monitor and freak out. And I'm like, your monitor has limitations. Your ears, your hands, your eyes are very useful. That's why when those students were in radiology kind of paralyzed, I'm like, somebody touch the dog right now. Somebody feel the heart, feel the pulse. Tell me if you like what you feel or like what you hear. And I wasn't trying to be abrupt, but sometimes you gotta snap somebody out of it. I'm like, wake up, touch the dog, listen to the heart. That's what's gonna tell you if your animal's okay, not staring at that screen. So an ECG can be useful as long as you are using it in conjunction with your other tools. And I've said this before, my old anesthesiologist boss, if he walked in an OR and saw a student staring at an ECG, he'd watch him for a while. He'd go over and turn it off. And he'd look at me and he goes, well, help them out. But they'd stare at him like, what did you just do? And he goes, you have a stethoscope, you have eyes, and you have hands. Figure it out. And I was like, okay, so as long as you're using, we'll give you all the tools to do that, as long as you understand the limitations. So, you know, obviously what we're trying to do is prevent the anesthesia accidents. It can happen. I have made mistakes. That's why I preach to you guys about all these stories is, you know, I've learned from a lot of mistakes that I've done. I have prevented them from becoming lethal because I was paying attention. So I caught the mistake or someone helped me or we worked together. We will talk about records because it is a legal document that could potentially be subpoenaed. If a client wanted to pursue legal action, they certainly could. And you have to make sure all drugs are written down properly, time that they were given, route. You can't just say ACE, 8 a.m. How much ACE? What route? Injectable? What time? Did the owner give it at home? Did we give it? So it all has to be documented because, yes, the dose that you were given. So I sometimes use dose and dosage. Now that I've taught pharmacology, I try to get better about that. Dose is what they were given. Dosage, I don't always write 4 mg per kg. I'll put fluffy ACE, 5 milligrams, 0.5 mLs, IM, 9:20 a.m. Okay, so I gave the amount that I gave in mgs and mils via what route at what time. And the anesthetic record has to be kept, and it is a legal document. So it has to be blue or black ink, can't be pencil, can't be your cute purple pen. You know, it's supposed to be blue or black ink, and it is supposed to be a medical record, and that it is kept. So everything will be documented on the anesthesia sheet, and then that is part of the record. And all of that is done just to have a good experience. So the whole kind of nuts and bolts, now this PowerPoint always kind of ends with key points, but the key points for this initial, then the next PowerPoint we're going to start tomorrow is going to talk about the physical exam, what we're going to talk about. That article I sent you yesterday does kind of have a flow of how we do a physical. And then I attached something that I didn't mention to you guys yesterday. There was a chart about breed-specific anesthesia. So hopefully you got that second PDF. One is a PDF that's multiple pages, kind of multiple chapters. The second one's just a sheet. Because there are certain breeds we're going to get into, you know, brachycephalics, boxers, sight hounds, like a greyhound. You know, we have to do different protocols for them. So that's what we're going to start to get into tomorrow. So this was kind of like, what is your role? What are the different terms we use in anesthesia? What is balanced anesthesia? And how do I do it safely? This whole thing is everything we're going to build on this term. So out of all that, do you have any questions if I unmute everybody for a minute? And one thing, I definitely, I hope you're not getting this feeling. I'm not trying to scare anybody. You can do this very safely. A lot of people do this very safely and are great anesthetists. You have to respect the process. You have to be prepared for the process. And if you do those two things and you prepare properly, you can do this safely. And that's what this whole, you know, term and term 2 is, building a database so that by the time you go to surgery, you know what you're looking for. And that's my goal. I'm Yes, Caleb, 100,000,000% what you just said. Be prepared, not panic. It's okay to be nervous the first time you do anesthesia. You wouldn't be normal if you weren't nervous. And like I said yesterday, my only thing that I ever ask students to do is to come prepared. And I had a student, it was the night before her surgery, she had a dog spay. And I'm not in surgery rotation, but she was like, could I call you and go over some questions I have? And I was like, sure. This was like 8 o'clock at night. I said, here's my cell phone. She called, she goes, ask me some questions. So I started asking her questions. I started troubleshooting. She had all her information. She goes, these are the drugs I'm using. This is what I should watch for, right? So I'm always willing to do that for anybody when it's your turn to do anesthesia. I'm always there.
Yeah.
So we talked for a good 30, 40 minutes that night, just going over things in her head that she wanted to discuss. But I appreciated the fact that
Zizzle, what did you learn?
What?
You did.
Yes, Zizzle, what he learned.
Well, I thought she was talking to me. But I appreciated the fact that she was reaching out. So, but I like what Caleb just said. Be prepared, not panicked. It'd be all right. Don't be nervous. Yeah, all right. You be all right. I will get you prepared. No worries. I probably don't need to be recording this.